Hello again and welcome to the second lecture. Now, before we begin this lecture, if you think your anatomical background is good enough, you can skip this lecture. And if you're not sure about that, stay with me and I'll make a quick anatomical review of the structures we need to know about to interpret chest X-ray. A chest X-ray is used to diagnose many conditions involving the chest wall, including its bones and all structures contained within the thoracic cavity, including lungs, heart, and great vessels. Now, to make sure we cover all these structures, there's a system called ABCDEF System. Each of these 6 letters refers to a specific anatomical structure, as A stands for airways, B for bones and soft tissue, C for cardiac silhouette, D for the diaphragm, E for effusions, i.e. pleura, and F for lung fields. And let's start with A for airways. Now, as you know, air is breathed in through the nose or the mouth, next into the pharynx, then to the larynx, which has a special flap of cartilage called the epiglottis that opens to let air pass through. From the larynx, air moves into the trachea, which is a cartilaginous tube that branches to form the right and left main bronchi. Then each of these bronchi branch into secondary and tertiary bronchi that branch into smaller airways called bronchioles, which eventually connect with tiny specialized structures called alveoli that function in gas exchange. Now, there are 3 anatomic airway structures that are typically visible on a normal X-ray. They are the trachea, which is normally in the midline, the right main bronchus, and the left main bronchus. Now, remember that the right side of the patient is the left side of the image, so here is the right main bronchus, and here's the left one. Now, I'll take the drawing away again so you can try to see the airways on your own. And the next thing we'll check in our system of reading CXR is bones. And first, the vertebral bodies. As we know, vertebral column is a series of approximately 33 bones called vertebrae, and this column can be divided into 5 different regions. The first 2 are 7 cervical vertebrae and 12 thoracic vertebrae. And the main part we see on a chest X-ray is the thoracic part. Vertebral bodies are more easily seen on a lateral film, but usually seen on PA as well, provided that the technical quality is adequate. Then there are the ribs, 12 pairs of ribs, and are all attached at the back to the thoracic vertebrae and numbered from 1 to 12 according to the vertebrae they are attached to, like the first rib here, which is attached to the first thoracic vertebra, or T1. Now, radiographically, we can recognize 2 components of the rib on a PA film. The posterior rib, which is easier to see and is oriented horizontally, and the anterior rib, which is harder to see and oriented at about 45-degree angle. For example, look at the 5th rib here. Here's the posterior horizontal part, and here's the anterior oblique part of it. Now, most of the ribs are joined to the sternum anteriorly, which can be seen on a lateral CXR here, and finally the clavicles, which are located up here. And then there is C for cardiac silhouette and mediastinum, which is better to evaluate them both at the same time. Mediastinum is the central compartment of the thoracic cavity, located between the 2 pleural sacs. It contains most of the thoracic organs like the heart and its vessels and the trachea, and acts as a conduit for structures traversing the thorax on their way into the abdomen, like the esophagus. Now, at the level of the sternal angle, we can draw a plane which separates the superior mediastinum above and the inferior mediastinum below. Then, the inferior mediastinum is further divided into 3 regions, all relative to the pericardium. The posterior mediastinum being behind the pericardium, the middle mediastinum contains the pericardium and its contents, and the anterior mediastinum being in front of the pericardium. Now, let's review quickly which structures of the heart we can notice by looking to the thorax anteriorly. First, Blood comes from almost all over the body to the heart via the superior and inferior vena cava, then to the right atrium, then the right ventricle. Coming out of the right ventricle, here's the pulmonary trunk which takes blood from the right heart to the lungs and branches into the left and right pulmonary vessels. Then the oxygenated blood comes back from the lungs via one of the four pulmonary veins to the left atrium, then the left ventricle. And finally, the aorta. The aorta starts as an ascending aorta, then travels superiorly from the heart, and then makes a hairpin turn known as the aortic arch. And following the aortic arch, the aorta then travels inferiorly as the descending aorta. Now, looking at the frontal projection, the cardiac silhouette can be divided into the right and left borders. First, the right border is formed by the right atrium and the superior vena cava entering superiorly and posterior vena cava often seen at its lower margin. Then the left border is formed by the left ventricle, the left atrial appendage, which is right here, and it's also called auricle of the left atrium, the main pulmonary artery, and finally the aortic arch, which extends superiorly. While on a lateral view, the cardiac silhouette can be divided into an anterior and posterior borders. The anterior border is formed mainly by the right ventricle beside the pulmonary trunk and the ascending aorta, while the posterior border is formed by the left atrium superiorly and left ventricle inferiorly, and the inferior vena cava. So simply right heart anteriorly and left heart posteriorly. And now moving on to D for the diaphragm. Diaphragm is the dome-shaped muscle that separates the thoracic cavity from the abdominal cavity. Normally, it's slightly asymmetric as the right hemidiaphragm is slightly higher than the left one due to the large liver directly beneath it. Here's the right hemidiaphragm and here's the left one. And we can see they are not at the same level. But this difference between hemidiaphragms should be about 1 to 2 centimeters and of course not more than 3, or it would be due to a pathological reason. There's also usually a small pocket of air visible under the left hemidiaphragm. This usually represents the air in the stomach, in which case it's called the gastric air bubble, although occasionally it can be unclear whether the gas is in the stomach or in the intestines. And now to the pleura and pleural space, in which the fluid can accumulate abnormally and cause something called pleural effusion, hence the letter E. So pleura is a thin double layer of tissue that surrounds the lungs, and it's divided into a visceral and parietal pleura, and the potential space between these two layers is referred to as the pleural cavity or pleural sac. And pleura forms recesses where the diaphragm and the thoracic wall meet. Two of them are seen on the BA image, which are called the costophrenic recesses or costophrenic angles. They provide potential space for the lungs to expand during inspiration and movement of the diaphragm, but at the same time, they represent a potential space for air, blood, and fluid accumulation, like in pleural effusion. On the lateral film, there is also another recess in the back, which is called the posterior costophrenic angle. And finally, and a very important thing we'll check in our system of rating CXR, are lung fields. Now, each lung is divided into sections called lobes. The right lung has three lobes, an upper, middle, and a lower lobe, divided by two fissures, the oblique fissure and the horizontal fissure, while the left lung has only two lobes, an upper and a lower lobe, which are separated by a similar oblique fissure. And if you're looking laterally to the right lung, and here I'll use a simple drawing, you'll see an upper and middle lobes in front and the lower lobe behind. While on the left lung, you'll see an upper lobe in front and the lower lobe behind, and the area of the middle lobe in the right lung, we call it lingula of the left lung. Now, let's see how this would appear on a chest X-ray. Actually, on a CXR, you wouldn't normally see the fissures most of the times, though it can be seen in some pathological cases, which we'll talk about later. Now, just to understand loops better, let's say that you found a focal lesion in the pulmonary field in a BA view in the left lung, something like this here. How would you guess which lobe does it belong to? You need a lateral view in which you can see that the lesion is located posteriorly, so it's almost in the lower lobe of the left lung. Now, it's hard to determine which lobe a lesion is located in, or whether it's located anteriorly or posteriorly, especially if you don't have a lateral view along with the BA. So, we can use a very helpful technique by dividing the lung field on a BA view into 4 zones, not lobes like that. The apical zone above the clavicles, upper zone below the clavicles and above the cardiac silhouette, mid-zone at the level of the hilar structures, and lower zone at the bases. Anyway, distinctions between these zones aren't precise, they are more arbitrary, so don't worry while reporting the CXR. Now back to our example. So here, which zone do you think the lesion is located at? Right, it's at the mid-zone. So, using the ABCDEF mnemonic, we'll check the CXR thoroughly. And that's the end of the first section. In the next section, we'll begin with A for airway assessment.